Hey, John Gilroy here. The Department of Veterans Affairs has 170 medical centers and 472,000 employees. Today, let's take a look at how AI can improve health outcomes. Hit the music, Manny. Welcome to the Federal Tech Podcast, a podcast that connects you to federal technology leaders. My name is John Gilroy, and I will be your moderator. We have two guests in the virtual studio today. We have Jeff DeLullo, Executive Vice President and Chief Region Leader for Phillips North America, and Mark Snyder, who is a retired Lieutenant Colonel in the Air Force. He's also a consultant for government business development for Phillips North America. A lot of hospitals, a lot of veterans, huh, gentlemen?
It's the largest single healthcare system in the United States. It is absolutely amazing, the size and scale of serving veterans in America.
And both of you gentlemen have military backgrounds, so sooner or later you're going to have to touch the VA, maybe in 20 or 40 years when you're dying or something. But you have a vested interest in this topic, don't you, Bach?
For sure. I mean, I am a member of the VA. They've taken great care of me, and it's like honestly, I was shocked how awesome it was as far as giving back and taking care of their service members. So look forward to any other ways that we can help accelerate the standard of care they get.
And here's the big surprise. I've been in VA hospitals throughout the country. Most recent one was in Oklahoma. So I know a little bit about the on the front thing. Okay, so you got this big company, Phillips, you got this big problem taking care of VAs. You got this wave of technology coming in. So, Jeff, where do you guys fit in? Where does Phillips fit in this big picture of helping out our veterans?
Well, interestingly, so I tell you they're the largest health system. They're also our largest customer globally. Now, our relationship goes back over 50 years with the VA. We've been serving them that long. And I'll throw you a few stats. But before I do that, what I'd share with you is our mission is to improve the lives of 2.5 billion people this decade, including 400 million in underserved communities. That's our global mission. We see veterans as a critical component of that. Our passion here in the United States is being able to extend healthcare to veterans. If we can do that, we can do it anywhere in the world. And so that's with the size and scale of the VA. It's a great mission and a testing ground. So a couple stats for us: we're the largest telecritical care program in the world, which means basically an EICU is deployed with the VA. So we use that as the model everywhere else in the world. 1 out of 2 radiology informatics systems in the VA is already a Phillips informatics system, and 75% of their clinical imaging systems for interventional surgeries or therapies with veterans are Phillips systems. And if you walk into a VA system today, there's better than 50% chance, any hospital in the VA network, there's 50% chance you will be attached to a Phillips piece of equipment when you walk in. So why? We love our veteran population. It's a part of our service and our mission to humanity. But more than that, we want to give back to those who have served so honorably.
So, Mark, I was in the hospital in Tulsa, Oklahoma. And if you go out west, a lot of veterans are in remote areas. I mean, that's just the way it is. I mean, they tend to recruit from that area, and that's where they reside. And so if you have a veteran in Logan, Utah, and has to drive 4 hours to a hospital, I mean, you're set up a situation where they can either get care or just kind of get by, and getting by ain't good enough, is it, Mark?
No, I mean, so, we're looking at ways to reduce that travel down to what's actually necessary, right? So Jeff talked about some remote options we have. One of the technologies that we've been working on is rapid analysis of threat exposure. That's something that DoD we developed under COVID-19, and honestly, it has some backbones going well back a couple of years prior to that to hospital-acquired infections. And so the idea is, we use this for our service members to reduce the likelihood of spreading infectious diseases. But what about someone from the VA that's 4 hours away? Rather than have them have to go in and check in with a doctor, this is a technology that could eliminate or at least reduce some of those inpatient visits, and we could go with telemedicine. I see that as something that's in the near future for us.
Yeah. So, Jeff, this whole concept of remote, back in 2018, if you remember that far back, it was there. People talked about it. COVID almost forced the situation. Now we have a situation where veterans probably heal better at home than in a hospital. And if there's a remote way to take and monitor that, or maybe do some predictive analysis, all of a sudden we have a win-win on many fronts.
Yeah, I'll give you 2 quick examples, and I'll preface this by the technology today, the medical technology today, the devices are scalable and deployable. The technology is not the issue. It's really one of change management and how you change your workflows to be able to do these things close to veterans. So, for example, you can put a patch on your chest and monitor a veteran at home in 3-4 hours away from a VA medical center where they would normally have to come in to get an EKG. We can do that at home and monitor for AFib and other scenarios, actually with real-time call centers, connect with them and say, hey, we see some abnormalities over the last few weeks. We'd like you to come in for an exam, right? That way you're only bringing a veteran in when they need to come in, and you can monitor at home. Another great example is with what I call our Lumify handheld device, which is basically an ultrasound on an iPad. So if you could imagine being able to equip all the 1,100 clinics in the VA system with an iPad-oriented imaging device, so you can get prostate exams, you can get all kinds of cardiac exams. You can do it right there at the local clinic. I don't have to make those drives. I was at the VA Medical Center in Fort Harrison in Montana last summer, and I also went to the Kalispell Clinic. Kalispell Clinic's 3 hours away. Those veterans are driving 3 hours, and some of them, elderly veterans or lack of mobility veterans, they really can't even get there. So we're actually bringing into places like the Kalispell Clinic that real-time diagnostic capability that has over-the-shoulder, bring it to the patient side from the VA Medical Center in Fort Harrison with the specialists. We can literally beam them in right to the bedside and get a much closer diagnostic to where veterans live.
So, Mark, we got to talk about prevention here. Last week, I wrote a check for $6,000 for a little roof problem I had here. And the reason I did that is because I didn't want to be spending $60,000 next year. So a little bit of prevention works. And so the way I understand this rate, rapid analysis of exposure, is that this can, maybe early detection, maybe improved health. All of a sudden, you're not spending the $60,000. You're spending a whole lot less. So if the focus today is on efficiency, well, this is prevention is efficiency, isn't it?
Honestly, we're just exploring kind of the tip of the iceberg right now. So what we saw with this in 2018, prior to COVID, we built this algorithm that's called RATE, and it's based on the backbone of about 300,000 patients worth of data in a hospital environment. And they're trying to see, there's a partnership between Phillips, Defense Innovation Unit, and the Defense Threat Reduction Agency. And they're trying to see, could we detect a hospital-acquired infection before someone has symptoms? And it's kind of a proof of concept thing. The answer was, yes, we can. And it's about 2.5 days prior, which is amazing. Well, then now roll to COVID-19. We reassembled that team and said, hey, could we use the same algorithm to detect COVID-19, but can we miniaturize it down on like little wearables like this that I have here that are commercially available, an Oura Ring or a Garmin Phoenix watch? And could we get at something that we don't know about yet and do a prospective study, look at this real time? And the answer was yes. And we were able to successfully detect COVID-19 about 2.3 days prior to someone popping positive. That's amazing, right? Just in itself, all of that is amazing. But we're not done yet with what we can do with that, right? So it's kind of a question of, well, what would you do if you knew you were about to get sick? Well, I don't know. I've never had that ability before, right? Well, maybe I don't go out drinking that night. I focus on good sleep. I focus on hydration, right? And then I kind of do a pat down on my body and look for those symptoms to decide what is going wrong. It's like a check engine light in your car. You don't just like pull over the side of the road and burn your car when that light goes on, right? You go to the mechanic and you're trying to get ahead of anything that's going to trash your engine, right? Maybe it's just a spark plug that needs to be replaced. A lot easier to do that. That's kind of where this technology is going. It is truly amazing. I might talk about this for years.
So, Jeff, I just thought of someone who got on a plane to Rwanda and was sick, but we're not going to talk about that story. That'd be an application, I think, right there.
That would be amazing application.
Yeah. So just limited to the VA, expands to other hospitals, what maybe even other agencies can use this technology, Jeff? Yeah.
So I want to copy what Mark was saying just for a second here at the DoD, because if you think about the special operations landscape, which is a design point for RATE right now, these guys are out on islands. These guys and gals are out on islands much more than they have been in the past, right? We don't have these large deployed logistics. So early degradation sensing matters, right? Before, somebody on a battleship gets sick and then you got the whole ship sick, and special operators in remote places. But there are also other applications in, say, the VA, right? So the staffing is going to be a continuing pressure for the VA. Being able to identify clinicians that might be exposed to things that could be getting sick can prevent and preserve that staff. You get them off the floor, you make sure they recover, and you keep the agility up of the clinical staffing models. And then I go back to things like RATE back at home. If I can send veterans home sooner, we know they recover better. So if I can have 160 biometrics being monitored and I can proactively connect with them if we see any potential degradation, I'm actually making a much better healing experience for veterans at scale with commercially available technology.
Yeah. So, Mark, I want to talk about Jeff's Donuts. So Jeff's Donuts in Chicago, they worry about security, but, not really much at all. Once you start delving into the area of medical facilities and hospitals, you have PII, all of a sudden people say, Jeff's Donuts, who cares? But, Mach Technology or Phillips Technology, we got to worry about security. So security, both you guys are military backgrounds, so this isn't going to be a surprise. This isn't a surprise question. So security's got to be built into this. Maybe first, maybe baked in.
It really was. That honestly, when we looked at all of the different wearables that were available in 2020, when we decided to miniaturize everything you would have in the hospital and just basically duct tape it on together to some small wearables, it became a pretty small list pretty quickly because of some of the limitations. We are obviously, there's a lot out there that are foreign made and foreign operated, and we just weren't comfortable with what assurances were given to us that data would not be sent somewhere else. We were also really concerned about GPS data being taken and sent, and we've seen that with Strava, unfortunately. We're concerned with people getting security violations going in places. So there are a lot of things that we had to ensure that the wearables didn't have as a starting point. And that narrowed it down to just a few. And then from those few that we had with Aura and Garmin, we went and validated as well the chain of custody, basically from the data from when it left the device to when it showed up at Phillips to ensure that there weren't any breaches. And then just as an extra layer, we did a layer of anonymity on there where no one was ever referred to by anything that could personally identify them. So everyone had random user numbers and letters that was their reference. There was no geolocation data. So we went a pretty long way to make sure that there weren't any violations or PII concerns. And on the flip side of that, right now, Phillips is working on making it more robust on different servers, like an IL5, IL4 server, to deal with the next future cases of where this thing can go.
Yeah. So, Jeff, we're also in that hospital in Montana and show them your fancy remote technology. Is this a bull in a china shop? Is this like, we don't interop with anything? And what about legacy technology? And there may be, let's say, humans there that, I don't know if I believe this remote stuff all the time. So how do you handle that, Jeff?
Well, fun fact, by the way, Mark, I don't know if I told you this. My daughter just got picked up in the special operations assessment. And the day she graduated from her assessment course, she got issued her Garmin and her Aura Ring to get on the program. So we're now feeding data from our family. You can edit that from the show. But that's just a fun fact. But in terms of, we think interoperability is a design point for us. So because we know no health system, to include the VA, has one single vendor for any specific thing. So one piece of infrastructure that we deploy is that we have to work, if we have a virtual capability, it has to work on everybody's platform. So that's number one. That certainly takes the ease of lock-in away from the dialogue here, because I'm able to actually interoperate the whole environment. The other thing is we see the VA and most commercial health systems are struggling with staffing today. And we actually think, because technology is so mature and scalable, and the need for staffing is only going to get more intense, making life easier for those clinicians that are serving patients by allowing some of this more virtual healthcare actually allows us to leverage more capacity. I can have a specialist from anywhere in the country dialed into a VA center anywhere. That's better capacity and lower burden on local staff. And it also takes the cost of that care down. But I think the need to find more creative solutions and the available technology is really what the compelling factors are today.
So, Mark, get out your history book here. Back in the day, they introduced IT, information technology, and that was fine, And then maybe a couple of years later, they had sensors on machines, and some people classified that as OT. Operational technology, okay. Then they had IoT. Now they have wearable technology. So Mark, where do you fit? We're in a classroom and get you up there on a whiteboard. And so is there a Venn diagram here, or is it you go to the back of the room?
That's a great question, and it's one that's interesting too, because we did this prospective study. We're going really fast because there's no vaccine available for COVID-19.
Mm-hmm. Of course.
Right? And so we were relying on this, even though it wasn't like a non-approved, research grade thing, we were using it to try to keep people home, get them tested early. But what do we call it? Is it a wearable algorithm? Is it an algorithm?
I don't know.
What is it? I think we're going to have a sit down here and figure out what the next level of what this actually is, because it's a combination of all of the above, right? The algorithm doesn't work without the wearables. The wearables don't do as good without the algorithm. So it's almost a full package deal here. Phillips, though, we're not in the business really of making these commercial available miniature algorithm or wearables that the companies have. But then these companies that make these aren't really in the business of making, hospital-like algorithms, so it's an interesting combination of future products that I think we're going to see proliferate, in our lifetime. But it is a unique beast, I think, for sure. On what do we call this? Where is it going? But it's truly an amazing, powerful combination of wearable data combined with AI that does stuff that's just imperceptible to the human brain. Like you could tell that your heart rate's going high. You could tell when your temperature is high. But when we put this through AI and it's deriving like 163 biomarkers, and it sets you off a high rate score and you feel fine. How do you, what do you call that? It sounds like something from Star Trek when Dr. Huxley's out there with the wand and waving someone down here. But I honestly don't think we're that far off from something like that.
Real quick here, Jeff, I took mock back history. I'm going to ask a forward-looking question for you now. And both of you have military backgrounds. Hey, 40 years, you're going to be in a wheelchair, and maybe you'll be in Tulsa, Oklahoma. And so what kind of... there's going to be an evolution in this. So, Jeff, how do you see these requirements changing? What technologies may exist when you visit old Mock when he's in a wheelchair down the hall from you? So what's going to happen in the future here, Jeff?
Well, I was going to comment on Mock's comment on commercialization, or what I call consumerization, has now reached healthcare, right? So you're now seeing this commercial ubiquity of IoT-enabled devices. Now it's about mastering the AI or the intelligence on top of that to give you that predictive diagnostic. I could imagine, and it's not very far off, where we're literally running a network where people are at home with devices that we're sending to them to put on that are easy, they're commercial, they already know how to use them, they're on an iPhone.
Yeah.
And then because of the security layers that Mark is talking about, we're actually able to communicate with them and tell them when they need a checkup or when they need a scan or when they need, and we can almost do all of that pre and post-op or post-procedures in the home.
They do that in my car. My car tells me I have to change. I mean, why not Mock? You need to get your blood pressure checked.
I think what's interesting, I mentioned the Lumify in the Kalispell Clinic. I always love to talk about them because they're amazing people that love their veterans. But we can actually today you can go to the clinic down the street, or you can go to a VA center, or you can go to your PCP. It doesn't matter. It's a short drive. And I'm bringing specialists from across the network right to your side. You're getting a real-time diagnostic as close to home as you could imagine. We can actually do it in your home. But we're actually developing now AI so that you could do your own transducer exam, and the machine will tell you how to point it, and you can have a real-time with your sonographer or your specialist, or you can have a real-time engagement, get your results just like that. You're not waiting for a radiologist to read them and get back with you and deal with that stress. It's in real time.
Yeah.
That's pretty cool.
Yeah. So, Mark, I was thinking about humans here. And so if I turn to you and go, hey, your blood pressure's kind of high there, Mark. And he goes, yeah, I know. I got this ring and everything else. But then we got to talk about changing behaviors. I mean, I think that maybe I asked the evolution question to Jeff. Maybe that is
It really is. I mean, that's the core question here is, let's look in the crystal ball at what the future looks like in 15 years from now. And I honestly don't think we probably can be inside of that. Yeah, you're going to talk about people changing their habit patterns based off of something that's imperceptible. It's like your check engine light. Your check engine light goes off and says your spark plug's bad, but your car feels fine. You're going to go ahead and change your spark plug, right? It makes sense, right? If I told you that, you just left the hospital, you have this gear on, and your score spiked, well, maybe you might have a hospital-acquired infection from that knee surgery. So let's get at that real quickly. Let's get you seen. Let's get some earlier blood work done, right? Let's get an earlier diagnostic test. And I think what we're going to see is that diagnostic testing that's typically done, 2-3 days after symptoms. We're going to shift that. We're going to find more sensitive testings, like what we saw with the PCR testing for COVID-19, that are able to detect this stuff when someone may not even be symptomatic. And now we're just talking about the garden variety things. Now let's talk about cancers.
Yeah.
I mean, like,
Yeah.
my gosh, what can we do now with that? We can say, hey, your biometric data is off. We can't really find a good reason why. Let's do the full body scan.
Hey, Jeff, in software development, they talk about shift left because they say, well, actually, shift left, we can prevent a lot of work after it's out the door. And so Jeff is going, yes, let's do shift left with healthcare. Maybe on your way home from the hospital, you get a monitor where your temperature is up and maybe it is an infection. I know the stories about that, MRSA and all that stuff. So maybe that's applying shift left to the medical community, huh, Jeff?
Well, prevention, an ounce of prevention saves a pound of cost. Sorry for the mixed metaphor, but it really saves a lot of money and lifestyle downstream. So, for example, if you can diagnose early stage lung cancer, which is very hard to do, the population that's most at risk for that with comorbidities, smokers, middle-aged, overweight, obese, or type 2 diabetes sufferers, those folks that typically don't get checkups and have the highest mortality rate, we can put a CT scanner or an MRI out into a community on a truck today and in real time beam up the diagnostic and give you a reading right away. But I want to go back to what Mark said is if people, ignorance is bliss. If you don't know about it, you're less likely to get. But today, because the Aura app is so gamified, my wife and I compare our sleep scores like every day. I didn't know to think about sleep score until I had the app. So because it actually has a gamification, which creates that awareness, which I think really has a potential to influence behaviors long term to be more preventative for people because it's right in front of their face.
Yeah, Mark, we're almost at the point now. Well, technology's pretty good shape. We can do a lot of predictions and analysis, and you can use algorithms and predict what's going to happen. But I think maybe that's the brave new world for you and Jeff down the road, Mark, is going to be this behavior change, because that's really where, especially with the chronic problems we see in this culture.
Yeah, I'll give you a couple for instances that we saw for the COVID-19 study. We had a little over 10,000 or so DoD service members. So we saw a lot of things beyond COVID-19. I think we captured something like 600 COVID-19 cases, but there were a lot of other things that happened throughout there. And one of my jobs as an investigator during that was just to reach out to people, make sure that the gear is working okay, and if they had a high score and they weren't reporting anything on their survey, to see if there was any anomalies going on with the algorithm so that we could apply filters and dial it down. We often had this happen where I would call someone and say, hey, you have a high rate score, just checking in, see if your survey's, been up there. They go, no, I just have like some sniffles. I think it's just seasonal allergies. And I go, well, we'll see. I mean, it may not be seasonal allergies, right? What about getting a COVID test if you're okay with that, And oftentimes it was COVID-19, right? So this is an idea that it's almost like a backstop to the human psyche, to say, hey, you may think you know your body, but maybe you don't know your body as well as this algorithm does, And it's like that. We all have that guy that shows up to work, call him Joe, that has a seasonal allergies around the cold and flu season, right? And it's right around Christmas time, and he spreads his cold and flu to half your workplace. Now everyone's going home for the holidays with that sickness. Well, this has a case to not do that. There was a case in the recent history where the Teddy Roosevelt had to go back into port because they had a norovirus outbreak, right? And that one rapidly spreads, right? I had it, unfortunately, like last year. There's a couple of symptoms you have early on, but it's almost too late, right? So something like this, you throw it out there. It tells you something's happening before you know it. So that first symptom, you go, well, I already know what's happening here. I'm about to, be out both ends. Let me quarantine myself. Let the command start isolating people, and let's avoid the outbreak that's about to happen, right? And so there's like a selfless portion of this as well for humanity's case there, where if you're sick and it's something that can be spread and communicable to other people, well, maybe you take one for the team and you don't go out that day.
So, Jeff, final question. I guess Mark brought up unintended consequences. You replace the water pump in your car and you notice that you have a strut that's bad. I mean, this almost like, this is a dream scenario where, we can prevent more than one thing. It's great, isn't it?
Yeah. So the entire healthcare ecosystem will suffer from increasing demand. People are getting older, living longer, needing more care. Staffing levels will continue to decrease as a percentage of total care, and the costs continue to rise significantly. What we talk about here, things like rate, is about much better predictive early intervention, shift left type of diagnostic capability closer to where people live. So the reach actually allows us to increase access to care earlier. And that the scale that healthcare providers are going to need, it gives us the opportunity to actually deliver more care to better people and optimize the staff that you have today. That's a mental health issue for staff workers. It's all well documented, and it definitely is a better outcome-driven thing. So to us, it's about reach and scale. And that's what I think the maturity of the ecosystem today with great technologies like Rate will only get better.
Yeah. If you're listening to this podcast and walking your dog, what I'll do is I'll include a link in the show notes for Phillips.com USA and talk about, especially in the government and some of these success stories. So it'll be fascinating to learn. This is it's great. I mean, it's the right, I think, product at the right time, given the demographics of our situation and the health concerns that we have. You have been listening to the Federal Tech Podcast with John Gilroy. I'd like to thank my guests, Jeff DeLullo, Executive Vice President and Chief Region Leader for Phillips North America, and Mark Snyder. He's a retired United States Air Force Lieutenant Colonel and Consultant, Government Business Development for Phillips North America. Gentlemen, good health to you.
Thank you.
And to you, John.